Case 21. Gastrointestinal, peptic ulcer disease. Scenario: a 52-year-old male construction worker presents to a community pharmacy with a primary complaint of burning and gnawing epigastric pain that has persisted for the last 2 months. He describes the pain as being temporarily relieved by eating food or taking antacids, but returning with greater intensity 2 to 3 hours after meals, often waking him up at night. He has a medical history of chronic knee osteoarthritis, for which he has been self-medicating with ibuprofen, 400 milligrams twice daily. A subsequent urea breath test, UBT, conducted at a nearby clinic returns a positive result for Helicobacter pylori. Question 21. Which of the following triple therapy regimens is the most appropriate first-line choice for H. pylori eradication and mucosal healing in this patient? A. Omeprazole 20 mg, BID plus amoxicillin 1 gram, BID plus clarithromycin 500 mg, BID for 14 days, B. Omeprazole 20 mg, BID plus metronidazole 500 mg, BID plus tetracycline 500 mg, QID for 7 days, C. Bismuth, subsalicylate 525 mg, QID plus metronidazole 250 mg, QID plus tetracycline 500 mg, QID for 10 days, D. Omeprazole 20 mg, BID plus ciprofloxacin 500 mg, BID plus azithromycin 500 mg, QD for 7 days. Correct. Answer: A. Omeprazole 20 mg, BID plus amoxicillin 1 gram, BID plus clarithromycin 500 mg, BID for 14 days. Clinical explanation: standard clinical guidelines recommend a P, proton pump inhibitor, PPI, based triple therapy containing 2 cornerstone antibiotics, amoxicillin and clarithromycin, as the preferred first-line eradication regimen. Extending the duration to 14 days guarantees significantly higher eradication success rates compared to shorter courses. Because this patient has a history of chronic NSAID, ibuprofen use, incorporating a therapeutic dose of a PPI, omeprazole, is essential to heavily suppress gastric acid secretion, promote ulcer healing, and protect the mucosal lining against future chemical damage. Case 22. Infectious disease. Scenario: a 35-year-old previously healthy female office worker presents to an outpatient clinic with a sudden onset of high-grade fever, 39.2 degrees Celsius, shaking chills, a productive cough yielding rusty-colored sputum, and sharp right-sided pleuritic chest pain. Physical examination reveals tachypnea, respiratory rate of 22 breaths per minute, and bronchial breath sounds with crackles over the right lower lung lobe. Her blood pressure is 115 over 75 millimeters of mercury, and she is fully oriented. A chest X-ray confirms right lower lobe consolidation. Her calculated CURB 65 score is 0, indicating she is an ideal candidate for outpatient management. Question 22. According to empirical treatment guidelines for uncomplicated community-acquired pneumonia, CAP, in an outpatient setting with no modifying risk factors, which antibiotic is preferred? A. Vancomycin, 1 gram IV every 12 hours. B. Amoxicillin 1 gram orally, 3 times daily, or a macrolide like azithromycin. C. Gentamicin, 5 milligrams per kilogram, IV once daily D. Ceftriaxone 1 gram IM as a single dose. Correct answer, B. Amoxicillin, 1 gram orally, 3 times daily, or a macrolide like azithromycin. Clinical explanation. For a young, previously healthy outpatient presenting with low-risk CAP, CURB 65 score of 0 or 1, and no significant comorbidities or recent antibiotic exposure, the primary pathogen to empirically target is Streptococcus pneumoniae. High-dose oral amoxicillin provides optimal coverage against S. pneumoniae, which remains the most common causative agent of bacterial CAP. Macrolides, such as azithromycin, serve as excellent alternative first-line agents, especially if atypical organisms are suspected or if the patient possesses a documented penicillin allergy. Broad-spectrum or intravenous agents like vancomycin, ceftriaxone, or gentamicin are clinically unnecessary for uncomplicated outpatient management. Case 23. Central nervous system, Parkinson's disease. Scenario: a 68-year-old retired teacher is brought to a neurology clinic by his wife. She reports that over the past year, he has become increasingly slow in executing his daily movements, struggles to rise from chairs, and has developed a noticeable pill-rolling tremor in his right hand when he is relaxing or watching television. On physical examination, the clinician notes bilateral cogwheel rigidity, bradykinesia, a shuffling gait with reduced arm swing, and a blank, masked facial expression. These symptoms are beginning to significantly interfere with his ability to dress and feed himself independently. He is formally diagnosed with idiopathic Parkinson's disease. Question 23. Which of the following medications represents the gold standard pharmacological intervention to directly address his disabling motor symptoms? A. Donepezil 5 mg orally, once daily. B. Levodopa/carbidopa, 100/25 mg orally, 3 times daily. C. Haloperidol, 5 mg orally, twice daily. D. Diazepam, 5 mg orally at bedtime. Correct answer, B. Levodopa/carbidopa, 100/25 mg orally, 3 times daily. Clinical explanation. Levodopa/carbidopa is universally recognized as the most effective treatment for the core motor symptoms of Parkinson's disease, particularly bradykinesia and muscle rigidity, in older patients. Levodopa is a metabolic precursor that readily crosses the blood-brain barrier, where it is converted into active dopamine, while carbidopa acts as a peripheral dopa decarboxylase inhibitor that prevents peripheral breakdown, drastically reducing systemic side effects like severe nausea. Donepezil is exclusively used for Alzheimer's dementia. Diazepam is a benzodiazepine used for anxiety/muscle spasms, and haloperidol is a typical antipsychotic that blocks dopamine receptors and would severely worsen Parkinsonian symptoms. Case 24. Cardiovascular, dyslipidemia, and secondary prevention. Scenario: a 55-year-old male with a history of essential hypertension and a documented myocardial infarction, MI, 2 years ago, presents to the cardiovascular clinic for a routine follow-up. He is an ex-smoker and reports strict adherence to his current medications, which include enalapril 10 mg BID and aspirin 81 mg daily. His blood pressure is well controlled at 128/78 millimeters of mercury. However, his fasting lipid profile reveals an LDL cholesterol, LDL-C level of 160 milligrams per deciliter, which is substantially above the recommended secondary prevention targets. Question 24. To lower his risk of a recurrent cardiovascular event, which class of medication must be initiated immediately, and what is its primary mechanism of action? A. Fibrates. Activation of PPAR alpha to lower systemic triglyceride levels. B. Statins. Competitive inhibition of HMG. COA reductase to block hepatic cholesterol synthesis. C. Bile acid sequestrants, binding bile acids in the intestinal lumen to prevent reabsorption. D. N-icotinic acid, direct inhibition of peripheral lipolysis in adipose tissue. Correct answer, B. Statins, competitive inhibition of HMG. COA reductase to block hepatic cholesterol synthesis. Clinical explanation. Patients with a history of clinical atherosclerotic cardiovascular disease, ASCVD, such as a previous MI, are classified as very high risk and require high-intensity statin therapy. For example, atorvastatin 40 to 80 milligrams, regardless of their baseline cholesterol values. Statins aggressively lower LDL-C by inhibiting HMG-CoA reductase, the rate-limiting enzyme in hepatic cholesterol synthesis. This cellular inhibition upregulates hepatic LDL receptors, clearing LDL directly from the bloodstream. Furthermore, statins exert critical pleiotropic effects, such as plaque stabilization and systemic anti-inflammatory properties, that drastically reduce the recurrence of ischemic events. Case 25. Hematology, anemia. Scenario: a 22-year-old female university student presents to the student health clinic complaining of profound, progressive fatigue, generalized weakness, frequent dizziness when standing up quickly, and a poor concentration span that is severely impacting her performance in lectures. She notes that her menstrual periods are typically heavy and last 6 to 7 days. On physical examination, she exhibits notable palmar and conjunctival pallor. A complete blood count, CBC, reveals a low hemoglobin level of 9 grams per deciliter and a low mean corpuscular volume, MCV. Further biochemical evaluation confirms a low serum ferritin level, and a peripheral blood smear demonstrates microcytic, hypochromic red blood cells. Question 25. What is the most definitive clinical diagnosis, and what is the preferred first-line oral pharmacological formulation for treatment? A. Megaloblastic anemia, oral cyanocobalamin, vitamin B12, 1,000 micrograms daily. B. Iron deficiency anemia, oral ferrous sulfate, 325 milligrams, 65 milligrams elemental iron, 1 to 3 times daily. C. Folate deficiency anemia, oral folic acid, 5 milligrams once daily. D. Autoimmune hemolytic anemia, oral prednisolone, 1 milligram per kilogram once daily. Correct answer, B. Iron deficiency anemia, oral ferrous sulfate, 325 milligrams, 65 milligrams elemental iron, 1 to 3 times daily. Clinical explanation: the simultaneous presentation of microcytic, hypochromic anemia, low MCV, severely depleted iron stores, low serum ferritin, and chronic physiological blood loss via heavy menstruation points directly to iron deficiency anemia, IDA. Oral ferrous sulfate is the clinical standard, cost-effective first-line therapy to safely replenish iron stores and restore physiological hemoglobin levels. Vitamin B12 and folic acid deficiencies characteristically result in macrocytic megaloblastic anemia with high MCV, whereas prednisolone is reserved for immune-mediated hemolytic processes. Case 26. Infectious disease, helminthic infections. Scenario: a worried mother brings her 7-year-old daughter to a community pharmacy. She reports that the child has been highly irritable, restless during sleep, and complains of intense, persistent itching around the perianal area, which characteristically becomes much worse at night. The mother mentions that several other young children in the girls' daycare facility have recently experienced identical symptoms. The pharmacist strongly suspects a pinworm infestation caused by Enterobius vermicularis. Question 26. Which of the following is the standard, recommended pharmacological treatment regimen for this child? A. Albendazole 400 mg orally as a single dose, repeated strictly after 2 weeks. B. Metronidazole 500 mg orally, 3 times daily for 7 consecutive days. C. Chloroquine phosphate 250 mg orally, once weekly for a total of 4 weeks. D. Praziquantel 600 mg orally as a single dose. Correct answer. A. Albendazole 400 mg orally as a single dose, repeated strictly after 2 weeks. Clinical explanation. A single 400 mg dose of albendazole is highly effective at eradicating mature adult pinworms, Enterobius vermicularis, within the gastrointestinal tract. However, because these benzimidazole compounds do not reliably kill pinworm eggs, the single dose must be repeated in exactly 2 weeks to eliminate any newly hatched larvae before they can mature into reproducing adults. Treating the entire close household simultaneously is also heavily recommended due to the ease of airborne and contact-based transmission of pinworm eggs. Metronidazole targets protozoa/anaerobes, chloroquine is an anti-malarial, and praziquantel specifically treats trematodes and cestodes. Case 27. Endocrine, diabetes complications. Scenario. A 62-year-old male with a 15-year history of poorly controlled type 2 diabetes mellitus visits his primary care provider for a routine evaluation. During the review of symptoms, he complains of a distressing, burning, tingling, and needle-like sensation in both of his feet that has gradually progressed over the last 6 months. He highlights that the pain is most severe at night, preventing him from falling asleep. A physical examination using a 10-gram monofilament confirms a symmetric loss of sensation to vibration, temperature, and light touch, extending in a classic stocking glove distribution. A diagnosis of diabetic peripheral neuropathy is established. Question 27. Which of the following medications is recommended as an appropriate first-line agent to manage this patient's chronic neuropathic pain? A. Ibuprofen 400 mg orally every 6 hours as needed. B. Amitriptyline 25 mg orally at bedtime, or pregabalin 75 mg, BID. C. Glibenclamide 5 mg orally once daily in the morning. D. Warfarin 5 mg orally, once daily adjusted by INR. Correct answer. B. Amitriptyline 25 mg orally at bedtime, or pregabalin 75 mg BID. Clinical explanation. Neuropathic pain arises directly from nerve injury and does not respond effectively to standard nociceptive or anti-inflammatory analgesics like NSAIDs, ibuprofen. First-line pharmacological options strongly recommended by international and local guidelines include tricyclic antidepressants, TCAs, like amitriptyline, SNRIs, like duloxetine, or gabapentinoids like pregabalin. These agents act by modulating central monoaminergic and voltage-gated calcium channels to dampen aberrant pain signals. Amitriptyline is strategically dosed at bedtime due to its sedative profile, helping to correct the patient's insomnia. Glibenclamide is an oral hypoglycemic agent, and warfarin is an anticoagulant. Case 28. Bone and joint. Gout. Scenario: a 50-year-old male with a history of mild hypertension wakes up in the middle of the night with sudden, excruciating, throbbing pain in his right first metatarsophalangeal, big toe, joint. He notes that he attended a large wedding feast the previous evening where he consumed significant quantities of roasted red meat and local alcohol. On physical examination, the joint is profoundly swollen, dusky red, warm and exquisitely tender to the point where he cannot bear the weight of a light bedsheet resting on it. His serum uric acid level is found to be elevated at 9.2 milligrams per deciliter. He is diagnosed with an acute gouty arthritis flare. Question 28. Which of the following represents the most appropriate initial pharmacological strategy to manage this patient's acute presentation? A. Initiate allopurinol 100 milligrams orally, once daily immediately. B. Administer high-dose NSAIDs, for example, indomethacin, or low-dose colchicine immediately. C. Initiate probenecid 250 milligrams orally twice daily. D. Administer glucosamine and chondroitin sulfate daily. Correct answer: B. Administer high-dose NSAIDs, for example, indomethacin, or low-dose colchicine immediately. Clinical explanation: the absolute clinical priority during an acute gouty flare is the rapid reduction of joint inflammation and intense pain using high-dose NSAIDs, such as indomethacin, naproxen, or low-dose colchicine. Urate-lowering therapies, ULT, like allopurinol, a xanthine oxidase inhibitor, or probenecid, a uricosuric agent, should never be newly initiated during an acute attack. Sudden shifts or fluctuations in serum uric acid levels can cause the partial dissolution and mobilization of monosodium urate crystals from tissue I directly into the joint space, heavily exacerbating or prolonging the painful acute attack. ULT should only be safely initiated 2 to 4 weeks after the acute inflammation has entirely resolved. Case 29. Pharmacy practice, storage and cold chain. Scenario: a pharmacist managing a storeroom at a primary health center in Ethiopia receives a fresh monthly shipment of various essential childhood vaccines from the Regional Health Bureau. The delivery container includes the BCG vaccine, pentavalent vaccine, rotavirus vaccine, and the oral polio vaccine, OPV. To prevent premature vaccine degradation and guarantee the complete structural integrity and potency of these immunological products, the pharmacist must immediately transfer them into the facility's dedicated cold storage. Question 29. What is the standard, globally recognized temperature range required for the main refrigerator compartment used to store these vaccines at the local health facility level? A. Minus 20 degrees Celsius to minus 10 degrees Celsius. B. Plus 2 degrees Celsius to plus 8 degrees Celsius. C. Plus 15 degrees Celsius to plus 25 degrees Celsius. D. 0 degrees Celsius to plus 10 degrees Celsius. Correct. Answer: B. Plus 2 degrees Celsius to plus 8 degrees Celsius. Clinical explanation: to fully preserve the cold chain at the health facility and user level, almost all routinely administered childhood vaccines, including BCG, pentavalent, rotavirus, and open/short-term storage (OPV), must be kept strictly within a refrigerator compartment, maintained between plus 2 degrees Celsius and plus 8 degrees Celsius. Allowing the storage environment to fall below plus 2 degrees Celsius can freeze and irreversibly destroy freeze-sensitive, aluminum adjuvanted components, such as the pentavalent vaccine. Conversely, exceeding +8 degrees Celsius accelerates the rapid thermal inactivation of delicate live attenuated viral vaccines, such as OPV and rotavirus. Case 30. Psychiatry, depression. Scenario: a 30-year-old female primary school teacher is diagnosed with major depressive disorder, MDD, after experiencing a continuous 3-week period of depressed mood, anhedonia, loss of interest in daily activities, profound lack of energy, significant changes in appetite, and early morning awakening. She is otherwise healthy and takes no other medications. During the treatment planning session, the physician requests the clinical pharmacist to recommend an effective antidepressant agent that has a favorable side effect profile, specifically minimizing daytime sedation and anticholinergic side effects, such as severe dry mouth, urinary retention, and blurred vision. Question 30. Which class of antidepressant medications is considered first line for this patient based on the requested clinical profile? A. Tricyclic antidepressants, TCAs, such as amitriptyline or imipramine B, selective serotonin reuptake inhibitors, SSRIs, such as fluoxetine or sertraline C, monoamine, oxidase inhibitors, MAOIs, such as phenelzine or tranylcypromine D, high-potency benzodiazepines, such as lorazepam or diazepam. Correct. Answer B. Selective serotonin. Reuptake inhibitors, SSRIs, such as fluoxetine or sertraline. Clinical explanation: SSRIs, such as fluoxetine, sertraline, or citalopram, are established as the first-line choice for major depressive disorder due to their broad efficacy, superior safety in overdose, and high patient tolerability. Unlike older tricyclic antidepressants, TCAs, SSRIs exhibit negligible binding affinity for histamine, H1, muscarinic cholinergic, or alpha-1 adrenergic receptors. As a result, they safely avoid the pronounced daytime drowsiness and highly uncomfortable anticholinergic side effects, such as severe dry mouth, constipation, or urinary retention, characteristically seen with TCAs like amitriptyline. MAOs require highly restrictive dietary monitoring, and benzodiazepines are strictly anxiolytics/sedatives that lack true antidepressant properties and carry a high risk of physiological dependence.